Hi, I'm Dr. Felice Gersh, your friendly, integrative OBGYN, and I'm speaking to you from Irvine, California on the day after Thanksgiving. So first, I hope you had a wonderful Thanksgiving. Quiet, but yummy. I spent all day yesterday with my husband and myself, and also visiting my almost 102-year-old mother-in-law. We're just a little pod. So it was lovely. My husband made a great dinner, and it was time to be thankful for the health that we have, for the loved ones in our lives, and for some of the breakthroughs involving the COVID-19 pandemic that we have all been suffering through in so many ways for so many months. So today I wanted to talk about some of the newest therapies. Last time I talked to you about some of the issues with the vaccines that were coming out, and we'll have more updates because there will be more to talk about. Today I want to talk about an update on therapeutics, talking about supplements that are evidence-based and also some of the new prescription types of pharmaceuticals that are available now to treat those who become infected by this novel coronavirus. But first, for those of you who have just found me and are new to my show, I just want to tell you a word or two about me. So I am a bit unique. I am board certified in both integrative medicine and in obstetrics and gynecology. I have a practice in Irvine, California, where I work every day, which is why I'm doing this at night, because I'm working all day long caring for my patients. And that is what I love to do. But as I know I can't see everyone, I like to do my Instagram live show and lots of webinars and podcasts so that I can inform and educate and help even those who are perhaps beyond my reach in terms of being able to come and see me. As a side note, I also do telemedicine though. So for people who can't actually show up in my office, I can deal with many issues via telemedicine. Once again, the name of my practice is Integrative Medical Group of Irvine, and my mission is to help improve the quality of lives every which way I can. Which brings me back to the topic for today. So let's start with some of the supplements. Well, first I'll tell you there's not that much new. I still have an immune support group of supplements, and I use immune support. We do not have anything that has guaranteed anything about preventing the infection from a coronavirus or preventing any sort of sequela from an infection. What we have are supplements that have data. We're talking about scientific evidence that they help you to have a more functional immune system in general. Now, the foundation of a healthy, functional immune system is not a group of supplements. It's all about quality lifestyle. It's about the food you eat, your fitness status, your sleep, your stress, your environmental toxin exposures, and such. So supplements, I always emphasize the word supplement, is an addition, a supplement to all the things that are foundational to helping you to stay healthy. And we've talked a lot about nutrition and stress and sleep and fitness, and we'll go back and talk about it more. But for right now, know that supplements do not replace any of those critically important lifestyle choices. So in terms of supplements, just as a brief overview and recap of some of the things I've talked about in the past are some minerals like magnesium and zinc and selenium, all of which have significant roles in immune function. And then we have some other supplements like N-acetylcysteine, which is a precursor to glutathione, which is known as the master antioxidant and king of detoxification. Helps your body to eliminate both naturally internally made toxins and externally exposed toxins that are now in your body. So NAC is a precursor for glutathione. As well, NAC helps with glucose transport, which is so important. We know that people who have diabetes and prediabetes, they do not fare as well in any realm when it comes to infections. So NAC is another one of the mainstays as far as supplements go. And I just want to spend a minute or two on some of the newer ones that I want to touch on. Some of them are herbals like astragalus, astrographin. Okay, so those are other ones that have some data in terms of supporting the immune functionality of the body. Okay, then melatonin. So there's been a few articles published about melatonin. Now, melatonin is known predominantly as the hormone produced at night to help facilitate sleep. And yes, it is very important in that regard. But melatonin wears many hats. It has many functions. It's a very, very potent antioxidant. So it helps reduce inflammation and free radicals, things that are very harmful to immune health. It turns out that one of the theories as to why little children do so well when they're infected with the coronavirus is that they have a lot of melatonin, far more than old people. As we age, we make less melatonin. Now, it also turns out there's now data that the SARS-CoV-2, the coronavirus that we're talking about that is the culprit in the COVID-19 pandemic, that particular coronavirus can actually affect the function and production of melatonin. So not only do you need melatonin as a potent antioxidant in the body and a support for the immune system, but the coronavirus may actually reduce your levels of melatonin. And that may be why taking supplementary melatonin may be beneficial. In one of the recent articles that I read, this is the dosing they recommended. They recommended anywhere from 3 milligrams up to a high of 10 milligrams for people who have significant risk. So they're not recommending it for every single person, like young, healthy people, but for people who have underlying pre-existing conditions that are associated with higher risk for the COVID-19 bad outcomes, and for the elderly, like 65 plus. So this is what they recommended, that you take 3 milligrams up to 10 milligrams. That's what the article suggested. Now, what do I suggest? I suggest that as a routine, if you're a high risk, that you have pre-existing conditions, that you go ahead and for the time being, not necessarily forever, that you do take 3 milligrams. And if you are exposed, you know you've been exposed, to jump it up to 10 milligrams. And you would take it anywhere from 30 to 60 minutes before you go to sleep. So that's what I would recommend, that not everyone, but people who have existing risk factors. So just as a recap, who would that be? People with hypertension, autoimmune diseases, obesity, cardiovascular disease, prediabetes, diabetes. So those are some of the, we'll say cancer as well, or cancer therapies. And once again, elderly, people 65 and over. So those are people that should probably be on the melatonin. And if you have a relative who meets those criteria, even if it's not you, you might want to share this information. As I said, this is from a peer-reviewed, published article that I located when I did my research. I'm always doing research. When I went through PubMed looking for peer-reviewed, published articles on the subject. Now, what about the pharmaceuticals? And we'll come back and touch on some of the herbals a bit later, down the road in our show when we have more time, and we'll talk about some of the herbals. But I really want to get to talking about the pharmaceuticals, because there have been a couple that have now received both approval by the FDA as emergency use authorization pharmaceuticals and also been approved. In terms of FDA approval, it would include some of the few things that have been out, and that would be the newest one that came out involving the IV, remdesivir. Now, remdesivir is really quite controversial. So remdesivir is an IV medication that's supposed to be used for hospitalized patients who have moderate and severe COVID infection. Now, the World Health Organization has specifically recommended against the use of remdesivir. How is that compared to the U.S., which the FDA has now approved the use of remdesivir? Now, how could they have such totally different positions? The World Health Organization is referring to a very large study that showed no increased survival benefit from remdesivir. And based on that, they said this drug has no benefit and should not be used at all. Now, in the U.S., they are referring to one study that showed that people who took it had 5 days of shorter hospitalization. That was it. No survival advantage, 5 days shorter stay in the hospital. And based on that, it was approved for use. So I am not very, we'll say, enthusiastic about remdesivir. Not at all. I think that's why at first it's like, what was the name of that thing again? Yeah, I am not impressed. I tend to side with the World Health Organization. If you don't show a survival advantage or really significant benefit to use a drug that costs thousands of dollars, I just don't really see it. And the study that showed 5 days, it wasn't that great. But nevertheless, it's out there. And you should know about it because who knows, maybe some family member or even you will be in a situation where a decision will have to be made whether or not to take it. So what else? Well, I wanted to just go backwards almost a minute to talk about hydroxychloroquine, okay? Several studies have been published since some of the earlier studies that suggested that it did not have benefit. That's what caused it to be really kind of put by the wayside. Well, more studies have come out, and these were not politically driven. I want to emphasize, not politically driven studies. They did not show benefit. In fact, they suggested even potential harm from hydroxychloroquine. Now, you may say, no, I've heard other doctors saying hydroxychloroquine is beneficial. That, I hate to say it, it doesn't count. Now, why doesn't it count? Because it's anecdotal. They're just saying, well, I gave it to patients and they ultimately got better. They didn't all die. Well, I wanted to bring up the hydroxychloroquine and tell you that I've looked at the studies, multiple studies. They do show no benefit or even potential harm. And when you do a study that is not double-blinded, placebo-controlled, you may be getting a lot of, we'll say, noise that gets built into that study that really isn't proving that it is beneficial. And we now have multiple well-run, non-politically oriented studies that really everyone was rooting for them to be beneficial, because who doesn't want to have a drug that is shown to be helping patients? These are doctors running studies. They want to help people. Well, it turns out they were not shown to be beneficial. Now, how could you have doctors out there saying, but it does help, when the studies show it doesn't? Well, let's jump over to another pharmaceutical that has been approved for emergency use authorization. So emergency use authorization means that the FDA has said under special circumstances, this can be used, even though it hasn't been fully vetted. It really has not gone through all the different steps that are normally required to get full approval. But in an emergency situation like a pandemic, once they feel it's shown to be safe and effective, even though it doesn't meet every criteria for being fully authorized, that they're willing to give it emergency use authorization. And these are the monoclonal antibodies. So monoclonal antibodies are now emergency use approved from 2 different companies, Regeneron and Eli Lilly. They each have their own different but similar monoclonal antibodies. These are delivered by IV, but not in the hospital, okay? And this is what makes it somewhat similar to hydroxychloroquine. So let's talk about monoclonal antibodies. Monoclonal antibodies are synthetically derived proteins that work as antibodies. Okay, so they're like antibodies that your bodies would be making, but they're actually manufactured to go against the spike protein of the coronavirus. Remember, they call it corona because it looks like a crown because of the spike protein. So what they created were artificially created antibodies to attack the spike protein of the coronavirus, which is a very unique protein. Well, this has to be delivered IV in patients who are proven to have COVID infection, and it should be when they have only mild disease, at most just beginning to turn moderate. It's for outpatient use only. In fact, it's been shown if given to patients who already are hospitalized and are in a very sick, severe condition with the coronavirus infection, that it increases mortality. That means it's found to increase death rate if you give these monoclonal antibodies, remember by Regeneron and Eli Lilly, to a patient who is already very ill, you increase the risk of dying. This is for early use only. Now, as I said, there's some similarity here in terms of how hydroxychloroquine was recommended to be used. Remember, it was supposed to be used early on, not in very sick patients. Well, let's see, what's the difference between monoclonal antibody treated patients and ones who got the placebo? Okay, so this was the data from Regeneron. Now, their data showed that when they gave placebo, that means not real, when they gave placebo monoclonal antibodies IV, the hospitalization rate was 9%. So this, and not just hospitalization, this was also people, remember these are all outpatients, people who became sick enough that they came back to the emergency room. So this includes not just people who got hospitalized and became deathly ill, just patients who ultimately needed to be hospitalized or just came back to the emergency room because their condition worsened and they felt they needed some attention. Well, the placebo group, their rate of coming back to the hospital emergency room or being hospitalized was 9%. The group that got the monoclonal antibodies manufactured by Regeneron, their percentage of patients who came back to the emergency room or were hospitalized was only 3%. So placebo, 9%, Regeneron, 3%. Now recognize that even the ones who got placebo, in terms of going back to the emergency room, it didn't mean they were even admitted, just that they went back to the emergency room because they had some kind of worsening, or they actually were hospitalized and not necessarily deathly ill. They didn't die, just hospitalized. That's all it was. It was still only 9% of the patients who were given the placebo. So just imagine you had people who were treated who were relatively low risk, not severe. They weren't hospitalized, and some doctor somewhere gave them hydroxychloroquine. The chance of that patient actually becoming deathly ill and dying or needing a ventilator was very small. I mean, that's the thing about this infection. That's the thing about COVID-19. The vast majority of people will not die. But even a small percentage, when you have a large population of people, as we do in the United States, it's enough to create havoc in our hospitals, our intensive care units, and affect the entire society. But that's why you have to really look at the absolute numbers. So when you have doctors who say, I used hydroxychloroquine and none of my patients died, that doesn't mean that it's because of the drug. Placebo did very well, but the monoclonal antibodies did even better. So who is supposed to get the monoclonal antibodies? Not everyone. They're not recommending it for everyone. There isn't even enough of it for everyone, not even close. It's for high-risk patients who are at least 12 years of age, including elderly over 65. It's really for all of those people over the age of 12 who get infected, proven positive that they are infected with COVID, and they have a high-risk status. So once again, like I mentioned about melatonin, who should take melatonin? Not everyone. The people out there who have existing risk factors that if they did become sick with coronavirus, that they will have a greater risk of having an adverse outcome, bad outcome. So the same thing for the Regeneron or Eli Lilly monoclonal antibodies. It's for patients at the very earliest stages. They have to be mild or just slightly worse than mild, all outpatient, and it's for people who have high risk of progressing to a very severe state and outcome once they are infected with the coronavirus. So you can imagine how difficult this is because it's an IV medication, so it has to be given in a setting that can do IVs, but not hospitalized patients. So it's not easy. It's easy if you're the president of the United States. It is not easy if you're someone else. And it's also something interesting to remember that when they gave this monoclonal antibody to very sick patients with COVID, they had higher risk of dying. So it's for a very unique, special population. It's not going to be given to the vast majority of people. So what are we left with right now? Well, the vaccines, I think, this is my personal opinion as a recap, that the Pfizer messenger RNA vaccine is the best one that's come down the pipeline by far. The reason is it doesn't have any additives to change its ability to withstand elevated temperature. And although it's certainly it's kind of an inconvenient thing that you got to keep it in such an incredibly cold state, like minus 60 degrees centigrade, something that along those lines. And the one from Moderna does not have to be kept that cold. It still has to be very cold, but not as cold as that. It's because they haven't added it. Now, that doesn't mean the additive is dangerous. I just don't know. And if I can avoid an additive, I will always prefer to not have the additive. I don't know how many people will have access to the Pfizer messenger RNA vaccine. I do want to still learn more about it, but that is the one that I am definitely in favor of. And as a side note, the one from AstraZeneca, not doing so well. A lot of problems now being found with their studies. They're going to have to do another study. So I don't know what the timeline is going to be for that one. I think they tried to sneak it in on us, and they were shown to have violated the agreements that they had signed about certain things. So in the end, the AstraZeneca is now back on the shelf, getting more investigative studies done on it. And the Moderna one is probably going to be approved for emergency use authorization, and the Pfizer one as well. So those are the two that will probably be coming out first. And if I had a choice, I would definitely choose the Pfizer one. That's my personal opinion. So we actually are still very happy with the use of dexamethasone. That's a steroid for severely ill patients, not early mild. It's supposed to be for the severely ill patients with COVID, and that also is working well. Now, what about the plasma that people have tried to donate that has the antibodies from prior infections of people? So it's turning out that that's not working out well, and that is also now falling by the wayside. So the plasma that contains antibodies from previously infected individuals is not working out as a good therapy. So once again, as they do more data collection, that is falling by the wayside. So why is it that survival rates are improving in the hospitalized coronavirus patients? partly because the age demographic is reduced, the ages are less, and also because they've learned much better. The doctors taking care of the patients in intensive care units how to manage their oxygenation better. They used to put them too readily on the ventilator, not understanding the unique issues involving this coronavirus infection. So they're not starting with or initiating the use of the ventilators anywhere near as rapidly. And they now have shown that putting the patients in a prone position, that means on their abdomen, is also helping to ventilate their lungs. They're using other forms of oxygenation like CPAPs more. And so basically, the understanding and treatment of the infection has significantly improved along with somewhat changing demographics, and also the use predominantly of dexamethasone. So that's the update for today. I'll be seeing you again soon. We'll be talking about so many different things over the next few weeks and the next year. So I hope that you will be a regular, and please let me know if there's anything that I'm not talking about that you would like to hear me talk about. You can send me messages through the Instagram. And I have not always been so great, but I'm going to really make sure I regularly take a look at them. So best wishes for the upcoming holiday season. Stay safe, stay well, make good choices, make good lifestyle choices every single day so that your immune system will be optimized and you won't need all these interventions I'm speaking of. Take care. Hope to see you soon. Bye.